Hello and welcome everybody. I'm so delighted today to serve as an opening act in today's webinar. Very excited to introduce it. It's going to be on female sexual rehabilitation in following pelvic trauma or cancer treatment. My name is Dr. Omar Rahim. I'm a urologist at the University of Chicago and also the ISSM Webinar Chair. It's really my extreme pleasure to introduce this topic. I think this topic is going to generate a lot of discussion from our esteemed moderators and speakers today. With that, I'd like to move to the next slide. Also, I'd like to allow the audience and the listeners to use this new features we have at the ISSM Zoom using translations and able to translate live during the live session here today. And please use also the Q&A section if you choose to. I think there is also able to see the questions also in your own language as well, which is we're very proud of that. A new addition to the Zoom. Being able to cater for a lot of audience who may not able to use the English language. Next slide. So really, the ISSM has been around for the last several decades. The vision and the mission of the ISSM is that every human being has the right to a healthy and satisfying sexual life. Next slide. As I said, the ISSM really founded in 1982, and the principal orientation of ISSM is now towards the whole field of a human sexuality, male, female, and also transgender population as well. The ISSM is the most respected and trustworthy form and conduct a number of webinars like today's one. We expect to have over 500 people registering today for the webinar. And through that, obviously, we're delivering the highest level information to the field of sexual medicine. Next slide. The ISSM has 7 affiliated regional societies, as you can see from this world map. All societies are active and involved in their region. They provide high-level information, education resources to their members and their patients. The ISSM act as a platform in which bring all the societies together and provide a mechanistic structure through we deliver the highest level of information when it comes to sexual medicine and sexual health. Next slide. So we do that through different educational platforms we have. Obviously, today's webinar is one of the most popular one for the last few years now. During the webinars, we provide really high-level information, more cutting-edge, instantly through Zoom. And it has been very critical for us to maintain that mission through Zoom. And I'd like to thank the faculty and moderators to be part of that as we go forward. But also, we have 4 flagship journals. The Journal of Sexual Medicine is the mainstay one. It publishes high-level scientific evidence in the field of sexual medicine. The Sexual Medicine Reviews, it's the highest impact among all the journals. As you can see, 5.3 recently, again, publishes really wonderful reviews on sexual medicine. And also Sexual Medicine Open Access, providing also sexual medicine articles. And lastly, we have the Video Journal of Obstetric Urology, the VJPU, a journal that's dedicated for surgeons who can get educated about high-level surgical techniques pertaining to sexual medicine. I'm really delighted today to have Professor Anna Maria Giraldi to join us today to moderate this webinar today. Professor Giraldi is a senior consultant and clinical professor of sexology at the University of Copenhagen in Denmark. Dr. Giraldi is an expert in the field of sexual medicine for men, women, and also transgender patients. She has published over 100 peer-reviewed papers, multiple book chapters, and editorials. Dr. Giraldi has held multiple high-level leadership positions, including the past president of the ISSM, ISWISH, and also the Canadian Society of Sexual Medicine. And also she has been the deputy editor of Journal of Sexual Medicine. So with that, I'd like to turn it to Dr. Giraldi and look forward to listen to her and her esteemed faculty in doing this webinar. Thank you, Anna Maria.
Thank you so much, Omar, and thank you for having me here. It's really a pleasure. I think the webinars are so crucial part of the ISSM, and I want to thank you, Dr. Rahim, for all the work you're doing in chairing the webinar committee. So it's a pleasure to be here, and just a few housekeeping words. We will have 2 presentations by excellent speakers, and I'll present them in a while. And after that, we will have the question and answers. So please put your question and answers under the Q&A button. And then I will go through the questions and I'll give them to the speakers. If you have a specific question for a specific speaker, please add the name for the speaker you want to ask the question. And also, as you can see, there's a lively trafficking on the chat. So please sign in, say where you're from, so we can all get in touch with each other, because that's one of the nice things about being in these webinars. So having said this, I just want to introduce our first speaker, Dr. Faisal El-Kak. Do we have a picture of Faisal? Okay, here it is. Dr. Faisal El-Kak is going to talk about female sexual function and recovery following childbirth, obstetric and/or pelvic fracture trauma. And it's really a capacity we have to talk about this. Dr. Faisal is a gynecologist, a senior lecturer, and a clinical associate and director of the Women Integrated Sexual Health Program at the Department of OBGYN at the American University Beirut Medical Center. He's also chair of the Arab Women Health Group, a federation of Arab OBGYN societies, and he's the past vice president of FIGO, the International Federation of Gynecology and Obstetrics, and recently he also got the position as a strategic technical expert in WHO. So it's a great pleasure, Faisal, that you have taken time of your busy schedule to give your talk today. So welcome to you.
Thank you very much, my friend. Thank you, Omar, and thanks for ISSM for inviting me to this webinar series. Hello, everyone. I'm happy to present on the really neglected issue, which is around the pregnancy, childbirth, and postpartum, where I'll be highlighting the burden of the sexual function dysfunction and come up with some recommendations. I have nothing to disclose. Next, please. We all know that how much women's health, sexual health is important and vital across the lifespan, and that includes pregnancy, childbirth, and postpartum. Next. And if you think today there is more than 200 million pregnancies every year, close to 125 million will have at least one sexual problem, and only 20 or 30 to 35 billion will be addressed. So imagine the size of neglect of this issue, especially that 91% of the pregnant women met the cutoff of sexual dysfunction according to the latest article in the contemporary OBGYN. Next, please. So this will bring us to think that hopefully this discourse around sexual health in obstetrics and the postpartum is really gaining some momentum and importance, and that's why ISSM is holding this session today. And this increased interest, however, is not really met by proper policies and by readiness of the healthcare providers. Next. But let's first see how sexual health does change across the 3 trimesters, according to several recent papers in this regard. Next. You can see that in the first trimester, for example, there is lots of interest. There is growing conscious of that the pregnancy is happening, and so the couple is being careful. There is decreased sexual function as measured by lower FSFI, decreased frequency of sexual activities. However, in the second trimester, the different reports mention that there is an increase in sexual function or there might be a decrease in the sexual function, but they all agree that in the third trimester, there is a drop in the frequency of the sexual function, the drop in the frequency of orgasmic experiences, in addition to less comfortable intercourse and possibility of vaginal penetration pain. Next. If you go in the first trimester exactly, although 50% will be desiring to have a sexual activity, between 27 or 28% up to 33% will report some decrease in sexual satisfaction and sexual desire. In the second trimester, as I said, as you see in this table, the numbers continue to be more or less the same on the various domains in the second trimester, but you can see there's a significant drop in the third trimester in the domains of desire, arousal, lubrication, and orgasm, as always per the FSFI scores. Next. Why is that? We all are aware of the physiological changes that are happening during the pregnancy, the symptoms that might happen, in addition to the psychosocial component of stress, also of the potential issue of a BMI, and also of other symptoms in the pregnancy. Next. After childbirth, these changes will continue, and all these factors affecting sexual function will continue and sometimes will also increase, because especially the desire, and that happens because you have physical recovery, there is breastfeeding, there is a new responsibility, there is now mothering, there is a change in the couple's life, there is fatigue, new demands, and pain, either due to estrogen or because of the existing perineal tears, whether this is a normal vaginal delivery or operative vaginal delivery. Next. That's why, if you look, this is the MAMI study from Ireland. If you look at the domains, there is also specific issues within the sexual domains that continue to exist from the early pregnancy all the way to the 12-month postpartum. Most importantly is the loss of interest, as you can see on the top, dark blue, followed by the lack of vaginal lubrication, followed by the pain during sexual intercourse, and these continue as domains and also as subdomains. Next. And if you want to explain why is this happening, this is a very interesting paper from a colleague at Hopkins. They published 3 plausible mechanisms. The first one is the severity of the perineal trauma. And you can see here that the peak one is for operative delivery using a vacuum forceps, followed by normal vaginal, followed by cesarean, although they all become similar after 6 months. The second mechanism, next, is related to the compression on the pudendal nerve and solidification. Look at the this is before labor in the slide in the figure A, while in figure B, at the second stage of labor, you can see there is a total compression of the pudendal nerve, and that leads to pudendal neuropathy, which might be responsible for some of the problems of sexual function. Next is the third mechanism, which is the mode of delivery. People have wondered whether delivering by normal vaginal or by cesarean plays a role in decreasing sexual function. Apparently, most of the papers pointed out if a normal vaginal delivery without any severe perineal tear is very comparable to cesarean section by 3 to 6 months after delivery. Other papers showed they are the same 12 months after concerning the return to sexual function. Next. Next. Yeah. So besides these 3 plausible mechanisms of pudendal neuropathy, mode of delivery, and perineal tear, there is also other causes I have mentioned earlier, like the low estrogen, like the mood changes, and the fatigue and the time constraints, which brings next the new concept of understanding the postpartum, which is the biopsychosocial model, if you want to look at this for clinical counseling and clinical intervention. Next. Next. In this model, you're going to look at psychological changes, at body changes affecting self-image, perineal trauma, hormonal changes, changes in the marital relationships, and sociocultural influences, in addition to the lifestyle changes. All these will factor in to shape sexual dysfunction in the postpartum and give you some hint as a healthcare provider. Next. So in this case, this is a very interesting article from Australia looking at not only like in 3 months postpartum, there is a reduction of sexual function across several domains, but around 50% will continue to report the loss of interest in sex, even 12 months postpartum, and 30% will continue to say repeated persisting pain. So even when there is a recovery for some, or for 50% of the postpartum, still another 50% will continue to have a loss of interest. And around 24% top were asked about this. So there is always little highlight on this issue in the providers. Despite all this, very little of percentage of women will be asked about these problems. Next. These are the two studies pointing that usually have more than one issue. Sexual function usually comes in 3 or 4 issues in the postpartum, and basically the most significant ones are sutures, suturing perineal tear, or episiotomy or instrumental vaginal birth keep on recurring as the main cause for this. As I said before, there are basically the pain, the lubrication issue, and the loss of interest that continue to happen. This is another paper from Vietnam looking at the impact of episiotomy on the domain of desire and of pain, somewhere between 60 to 70%. Next. This is just to emphasize that please do not at all counsel your pregnant woman that it's important for the sexual function between normal vaginal and cesarean. They are the same. There was no influence 6 to 12 months. In other papers, up to 18 months, there is no influence that remains on sexual function between normal vaginal without severe perineal tear and cesarean section. Next. Next, please. This is another paper looking at the degree of bothersome. So there is not only a level of loss of sexual function and decreased desire and pain and stuff, but there is also a pelvic floor dysfunction that remains up to 1 year and more, and it's bothering to the woman, up to 43% in case of emergency cesarean, and up to 40% in case of operative delivery. Next. So there is also this level of anxiety. And this is a very interesting article that I really wanted to share. It's about the sexual response that's not felt by the woman, but it's also proven by the FSFR, where the genital trauma and the breastfeeding could have negatively impacted SFFI, the female sexual function index, and there is the genital response of the woman without any subjective response. So that's very interesting also to look at. I wanted to share. Next. So what do we have now? Before I finish with the clinical intervention, we have the main issues that are the pain, the libido, the lubrication. The most important contributing factors are the perineal tears, low estrogen, and the psychosocial factors. The literature speaks about several interventions like counseling, CBT, pelvic training, non-pharmacologic and pharmacologic interventions. Next. Next, please. Next. So, one of the interventions is to do something called the prophylactic interventions, like starting perineal massage and stretching 6 weeks prior to delivery, 10 minutes daily in primipara, and 9% reduction of tears and trauma will occur. Mindfulness is very important because it enhances woman control over the process of labor and delivery and reduces anxiety. Next, please. At the same time, avoid direct and Valsalva pushing that we do often as obstetrician, and also birth positioning is important. Non-supine can lower the risk of tears, the episiotomy, and it's more comfortable for women. Next. These are simple interventions. The other intervention is about counseling. It's important that you don't have one size fit all. Don't promise everybody you're going to have your sexual function back in 3 months or in 6 months or in 12 months. although 97% will return to sexual function in the postpartum by 1 year, but you have, according to these papers, to have to do it a case by case, depending on the type of delivery, depending on all the other factors I mentioned in the biopsychosocial model. Next. The most important is you have to encourage women to seek care. It's really, really very low to seek care around sexual health after the postpartum, and always counsel on a range of emotions to promote intimacy, like non-coital activities and the positions. Next. When it comes to also the counseling, the effectiveness of the implicit model in solving postpartum have been shown in this paper by colleagues from Turkey, showing that by using the intervention with the implicit model, it reduced the postpartum sexual problems, because you showed what is normal, what's abnormal, what's expected, not expected. So it makes it easier for the postpartum to understand these changes. Next. Regarding CBT, this is a recent paper published last year, 8 weeks of counseling once a week using FSFI and sexual self-efficacy questionnaire before and 8 weeks after the last session. And you can see it was significant across all the domains, which led to the conclusion that proper implementation of counseling based on CBT model improves sexual function and self-efficacy after childbirth. Next. Regarding the pelvic floor, it's important to notice the study on my left-hand side. Like 2/3 of the premenstrual women, 1 year after delivery, they suffer from the pelvic floor dysfunction bothering symptoms. So this is important to pay attention to this. This is a paper from Brazil on my right-hand side, using the pelvic floor muscle training with various frequencies, 2 per week, 1 per week, depends on the provider. And you can see on the 3 curves, there is an improvement in the SFFI, reduction in the stress, and also improvement in the vaginal manometry, thus giving credit for the pelvic floor muscle training as a way to reduce sexual dysfunction and improve function in the postpartum. Next. This is a systemic review and meta-analysis of the clinical trials appearing in 2019, showing that all the studies reviewed are in favor of the pelvic floor muscle training, whether it's a primary or multiparous woman, boosting sexual function and quality of life. Next. It's important to realize who are the women who's going to seek care for pelvic floor muscle. This is from a great journal showing that women experiencing urinary leakage and pelvic girdle pain are more likely to do pelvic floor muscle training. On the other hand, from the Brazilian study on those suffering from obstetric anal sphincter injury, those who had been explained very well the risk of perineal tears and the anal sphincter injury are more likely to come and seek care. And those who know more about the OASIS also will come and seek care for pelvic floor as compared to the others. Next. What about using pharmacologic treatment like estrogen creams? This is a very small study. It's a placebo-controlled trial, giving twice-weekly estradiol cream versus placebo, and looking for vulvovaginal symptoms at 12 weeks using FSFI and vulvar assessment scale. Really, it was important that the reduction of the vulvar atrophy symptoms in the postpartum, but there was really very minimal benefit in the overall sexual function. Next. You can always use lubricants, preferably the water-based lubricants in case of the lack of lubrication and vaginal pain, or silicone-based. Next. Also, moisturizers that are very familiar with this. You can use the Replan or the KY or the others, whether twice a week or 3 times a week, depending on the brand. That also is helpful because it retains water in the vagina, it creates more sensitivity and reduces the pain. Next. This is about a review, and that's my last slide, I think, about the fractures and female sexual function dysfunction after pelvic fracture, and if that might happen in childbirth, which is a very rare occurrence. In this fresh review I've been looking at, as I said, it is in general, it is not uncommon because we think it is rare. It is not, especially in young women. It is there and can be morbid. Okay, it continues to be underreported, and the recommendation is you have to screen patients for FSD, those reporting pelvic fracture, because they report all types of sexual dysfunction, from pain to lack of desire and others. However, unfortunately, in all these review of literature, there was no algorithm for looking at assessment of these conditions, and there is no treatment, like consensus treatment, available for these cases. My last slide is about recommendation. Definitely, my recommendation is we have to highlight this. And I think ISSM was, and all the other groups interested in the regions and in the countries should really train, provide resources to allow the healthcare provider to really look at this important yet neglected issue during pregnancy and postpartum, whether this is in the curriculum, in the pre-grad, in the grad, in service training, and later on as standalone courses. Next. I want to thank you, and this is our program at the university. It's called the WISH program, where we deliver sexual health care across all the walks of life in the lifespan of women and her health and illness conditions. And thank you very much, and I'll be happy to wait for your questions later on. Thank you.
Thank you so much, Faisal, and excellent talk and so much knowledge. I know you work quite a lot to identify all these newspapers, so thank you so much. So now it's a pleasure to introduce our next speaker, which is Daniela Wittmann. She's going to talk about female sexual function and recovery following cancer therapy. Daniela Wittmann is an associate professor emerita of the urology and an adjunct associate professor of social work. She is a lead faculty in the Brandon Prostate Cancer Survivor Program and works in many aspects of sexual health in both men and women after cancer and cancer therapy. And that is also her special research interest in what is the quality of life and sexual health after having cancer in cancer survivorships. She uses different methods, mixed methods, qualitative studies, quantitative studies to study her research interest. She's also an associate editor of the Journal of Sexual Medicine. So welcome to you, Daniela.
Thank you very much for that kind introduction. And it's a pleasure to be here, part of this esteemed panel. Next slide, please. These are my disclosures. Next slide. So in this figure, you can see that women live with cancer into survivorship. For some women, it is, and for some cancers, it's not very long, but for many, it can be quite a long time. And that's when quality of life becomes really preeminent and important. And sexual health is an important element in experiencing life as being full. Next slide. Cancer has impact on sexual function, but people get treated pretty quickly. So then it really becomes the treatment that has the most impact. Surgery, particularly if it's in the pelvis, can be quite dramatic in the way it affects sexual function. In some cancers, pelvic cancers, women lose parts of their genitalia or all their genitalia and their vagina, their uterus, their ovaries. And so they lose the pleasure centers and the functional centers of their sexual lives. If they lose their ovaries, they are prematurely sent into menopause. If they lose their clitoris, they lose an important source of pleasure. But it's not just surgery itself, and you can just imagine that with the organs, the neurovascular structures around them are either disturbed or severed altogether. And those neurovascular structures also contribute to sexual functioning and sexual pleasure. On the right, you see highlighted in blue the organs that women may lose, for example, in ovarian or bladder cancer, that are really the very organs that are a part of a woman's sexual experience. But it's not just those surgeries. On the left, you can see women who are disfigured by cancer surgeries. On the left, a woman loses a breast, so she loses the sensation, a sexual sensation of a nipple. In the middle there, you see a woman with a head and neck cancer or oral cancer who, if she loses salivary glands, she may have trouble kissing, performing oral sex, and the whole experience of sexuality will be altered. Next, please. Radiation to the pelvis has an impact on all the structures there. It can lead to neuropathy, fibrosis of the tissue, scarring, atrophy of genital structures, which means that the tissues there are going to be much less flexible and responsive. And so women can develop poor lubrication, they lose sensitivity, they can experience vaginal stenosis, and that leads to pain with penetration. Hormonal therapy, when women are deprived of estrogen, which is kind of the biological substrate of their sexuality, they experience vaginal dryness, and that leads to pain with penetration. But even cancers that are not focused on the pelvis at all, chemotherapy can change the quality of women's skin, particularly the mucosa in the mouth and in the vagina, and even blistering, and that certainly can contribute to problems experiencing pleasure when kissing or when experiencing penetration. Finally, fatigue accompanies most cancer treatments, and that in itself reduces desire and arousal. Next, please. Research tells us that really across cancers, across ages, the majority of patients experience treatment-related sexual dysfunction, certainly often soon after the treatment, and sometimes long into survivorship. And so it's really very important that we pay attention to that aspect of the patient's lives, even though in other respects, their quality of life and their ability to live a reasonably full life is sort of returns. The sexual function and the sexual experience may not return as well as other aspects of their life. Next, please. So now I just spoke to you about the aspect of sexuality that is measured most often and that we have most information about. But we really have come to see that sexuality is a much more complex experience, that it's not just the biologic changes, that when women experience changes in their bodies and their sexual ability is reduced, they have many feelings about it. They get anxious, they get depressed, they become fearful of not being able to satisfy their partner, and may begin to avoid sex. And their partner's sex lives, even though their sexual function hasn't changed, are also inevitably altered. Now, research tells us that couples don't always effectively discuss these things. And then if they don't discuss them, they may diminish their ability to have sexual interactions, or maybe even lose their sexual lives. Finally, all of us live in a social and cultural environment, and our religious, philosophical, cultural, traditional beliefs affect how we experience our sexuality, how dysfunction is viewed, and what rehabilitation will be acceptable. Next, please. So let me just speak a little bit about the psychological impacts. Women report feeling embarrassed, fearful of rejection, anxious, maybe isolated and lonely. I mentioned to you low desire, and that really doesn't just come from the biological changes in the body. It can also come from the fact that women lose control over their body functions. They begin to feel less capable. So the self-esteem goes down. They begin to worry about their relationships. And in many cases, their reproductive abilities are affected as well. And so all these psychological responses can decrease their interest in sex. One of the specific things that has been identified as an important component of the psychological response, and it makes sense, is grief and mourning. People mourn their sexual losses, and often they do it quietly. This paper by Pillai, Friedman, and Ashline points out that patients often feel grateful for having had their lives saved, and when they have sexual problem, they don't feel entitled to ask for help. So they call it disenfranchised grief. And it's our job to make sure that patients don't feel disenfranchised in this domain. Next, please. I already mentioned that partners' sexual lives get altered if they have a partner who is a cancer survivor, and they grieve the losses too. They may want to have more sex than the patient, and they may feel guilty. They can become resentful and withdraw. And research has shown that couples don't really effectively communicate about sex because they can have nonverbal sex for decades perfectly well. But when they start having problems, they need that skill and they have to learn it. Culturally, it's important to recognize that some women live in societies where the culture is male dominant. And some of the research shows that some of these women, first of all, would never dream of asking for help, of accommodation, but also that they persist with sexual activity even to their own detriment, and put up with a lot of pain and discomfort, and may begin to dread their sexual relationships because they become so unsatisfying, but they don't feel able to change them. Next, please. So it is the clinician's job to start the conversation. Patients don't always feel able to do that themselves. And when we do that and start talking to them about the sexual side effects of the treatments before treatments, they benefit when they know what to expect. And then they also feel relieved if they know that some form of rehabilitation may be offered to them afterwards. Sometimes patients have unrealistic expectations of their own outcomes, thinking they're going to do better than what they read about or what they told. And so having a credible source that educates them can reduce those unrealistic expectations as well. Next, please. When planning a sexual rehabilitation, based on the biopsychosocial model that I told you about, that perspective, it's important to address all the aspects of sexuality at once. At least in the assessment, one has to make sure that one understands what kinds of help people need. Is it just functional in a really well-functioning couple? Is it patients very depressed or partners very depressed about it all? How they doing? So we don't know what we're going to be helping them with until we do a biopsychosocial assessment. We have learned that we need a multidisciplinary team of people with different expertise who can help educate patients, who can help with physical problems, who can help with mental health and sexual health problems. So it's really necessary to organize a multidisciplinary team to help those patients. Next, please. One of the kind of innovations that surgeons have been working on that I wanted to share with you is trying to see, given what losing organs and neurovascular structures does to sexuality, trying to see whether, if oncologically safe, there is a way to spare some organs, neurovascular structures. And they're trying to learn in bladder cancer from people who do hysterectomies, because they sometimes try very hard to save the pelvic nerve plexus to enable women to continue to have some level of sexual function, and that can then be measured by measuring blood flow, and then patient-reported measures of such as the FSFI or the PROMIS to see the patient's experience. Next, please. But the more traditional things that women are offered are vaginal lubricants. Next. Vaginal moisturizers. Next. Dilators, vibrators, and possible hormone replacements such as a estradiol vaginal ring, vaginal insert. Next. Or a vaginal cream. Pelvic floor rehabilitation is extremely helpful next because especially when women have had radiation to the pelvis, they may have scarring that can be released. In pelvic floor rehabilitation, they may have tense muscles because now they're afraid of penetration. That can be helped. Sometimes they have entrapped nerves. So pelvic floor rehabilitation, physical therapy is extremely valuable to women after cancer treatment. Sexual desire, particularly, I want to go back to the hormone replacement. Hormone replacement has to be balanced with oncological safety. So particularly safe for women who have non-hormone responsive cancers and, clinically evaluated for women who do. So sexual desires can be enhanced by flibanserin. It's a medication that was tested in premenopausal women. In randomized controlled trials. It's a daily medicine. Next, please. And it has also been tried with postmenopausal women, and many of the women after cancer treatment basically have that kind of a postmenopausal syndrome. Next, please. Here are some evidence-based interventions that I wanted to let you know about. Most of them are basically pilots, but still worth knowing about. Laser therapy has helped women with vaginal comfort. The combination of olive oil, pelvic floor exercise, and a moisturizer has also improved women who've had problems with vaginal penetration. There are two, so those are biological interventions. There are a couple of, actually 3 psychoeducational interventions or psychological interventions. Psychoeducation can be very helpful in, again, educated women about their sexual issues, their sexual concerns, and suggest rehabilitation, and that has been helpful with breast cancer patients. And for quite some time already, group mindfulness-based cognitive behavior therapy has been helpful with increasing arousal in women without breast cancer, with breast cancer, certainly in the cancer domain. So it can also lead to reduction of distress in these women. Next, please. When patients are referred to sex therapy, and let me just tell you, many women and their partners do very well with education and support. But when the problems persist and women need additional help, they can be referred to sex therapists. And the first job of sex therapy is to address grief work and normalize it for the women and for the partners, because they have a lot of negative emotions about what's happened to them, and that returns periodically. Then if there is anxiety about returning to sexual activity, sex therapists use sensei focus exercises to help start with non-demand sensual interactions and move slowly to sexual interactions. Women and their partners are encouraged to expand their sexual repertoire to non-penetrative sex as well, such as oral sex, manual stimulation, vibrators. Culture will play a lot of big role there to what's acceptable. Couples are encouraged and taught how to communicate about sex if they don't have that skill. And sex therapy can also address pre-existing relationship or sexual problems. Next, please. It is often easier to start the conversation with a kind of a brief screener, which was developed by Dr. Bober and colleagues. It's very brief, and it legitimizes the patient's concern and can make the clinician more comfortable as well. Next, please. Patients can look for resources on the website of the American Cancer Society that's available worldwide, and providers. can learn more about sexuality and cancer through ISSM University. Next, please. So to take home points, take home messages are that women experience sexual dysfunction and sexual distress individually and in their relationships after cancer. Although many women do not return to baseline, they can work with their partners towards a satisfying sex life if they grieve their sexual losses, use sexual aids, and expand their sexual repertoire. And it's our responsibility as clinicians to learn about the relationship between cancer treatment and sexual side effects, ask the patient about her concerns, and direct her to resources. Thank you.
Thank you so much, Daniela. And thank you to you too, Faisal. And wonderful presentations. And what strikes me is that when people in sexual medicine meet, we talk so much about the impact of especially cancer, but also about giving birth. I think this is very important also to gynecologists. And we always say we need to address this with the patients, and we still really have problems in doing it. So I think this is really, that's why it's so important that you're both here today. So I have a question first for Dr. Faisal. And the Faisal is, are there further studies underway to help healthcare providers understand that the recommended interval for resumption of sexual activity is more varied than the typical recommended, which in this case is said to be 6 weeks, at least in the US. Additionally, of course, we need more education of healthcare providers to realize that sex is far more than PIV. Sex too. I'm sorry, I don't know what PIV is, maybe, but it feels like an important public health campaign.
PIV is like penis in the vagina.
Oh, thank you. I'm just so ignorant. Sorry. I'm just thinking, what is PIV? Yeah, that shows my ignorance. Sorry for that. Thank you for helping me. So I think that it also brings that different cultures might have different recommendations. And what do you, I mean, you've been involved in FIGO. So is this something that we might expect that you can come out and say, we really want to talk about this? What are the recommendations?
Well, thank you very much for the question. Definitely, there is a growing interest, I think, globally with the sexual health to be brought and to be effectively addressed at the clinical care levels. Second, there is this thing with the 6 weeks in obstetrics, like 6 weeks postpartum, 6 weeks follow-up visit. 6 weeks need to be revised because there is a whole psychosocial model or even biopsychosocial model that you have to address, and it differs from one person to the other depending on their mental health, psychological status, social support, partner support, single mother versus not single mother, adopted versus not, several factors, perineal tears, type of delivery, operative, non-operative, vaginal, cesarean, the old circumstance. So although in 1 year most of them will return to sexual function, but we're not sure the quality of that sexual function and what is really is bothering them in that sexual function, if it's still bothering them or not, and whether they are returning to the sexual function because of the satisfaction or satisfying the partner or not in a heterosexual relation. So in this case, I think there is no one size fits all. It's a case by case. You have to understand every case. But the most important thing, Professor Girardi, is that, you know, most of the women with the sexual dysfunction, they think it's normal. It's normal for them to stay 1 year with the sexual dysfunction because no one is talking about it. So I think the most important thing is to let the woman feel there is a safe space for them in the postpartum to talk about sexual function and address it. And at the same time, I think we need to build the skills. And I call upon ISSM, WAS, ISWISH, and all the concern to really raise the skills of the provider to address an issue happening to 200 million women, 200 million deliveries per year. And I have seen the numbers, up to 120 million can have some form of a sexual function. So this is huge. And I think we need to set some kind of algorithm of practice, some kind of a guideline that people in different cultures, in different societies can address this. You cannot address the same recommendation for somebody in North America, like somebody in Southeast Asia or the Middle East, or there's a whole different thing that you have to assess based on the biopsychosocial model.
Thank you so much. And Daniela, how does that apply to cancer treatment? Because as Faisal says, maybe we think this is something that's so normal. So, and people say, I often have patients saying, oh, I have cancer, I'm so happy I survived, so I don't want to be like, what more can I expect? So maybe
Exactly.
we think something is very normal. And there's also a question, maybe you can comment on that, Daniela, too, how we relate it to cancer treatment, but there's also a question about the importance of sexual counseling to women and the partner before surgery and treatment for cancer. And sometimes I find it's difficult to actually counsel because people never know what happens, and they don't know that how bad it's going to be or how it's going to be bad, or you don't want to scare them more than they already are because they have cancer. And I think maybe also when they're pregnant. So what do you think, Daniela?
So my experience is that clinicians often assume that patients are not interested. And there may be some who are not. They're so overwhelmed with the cancer and worry about survival that they may not be interested, at least at the beginning. But the interest can come afterwards when their overall quality of life improves. And now they think, oh, what about this part? And they, of course, also have partners. And the partners have to wonder about what's going to happen to them and what's going to happen to their sexual lives. So my experience has been that it's most helpful to introduce it at the beginning, but different people have different tolerance for what they want to know at the beginning. And it's probably not that useful to go in a ton of detail. As you say, it's you don't know the extent of the treatment, you don't know specific side effects for that person. But I think a high-level introduction, letting people know that it becomes of interest later on, that there are resources available. This is what I think is important, because people need to feel that if down the line they have sexual concerns, that it's a legitimate area for them to ask for help. And I would imagine that's true in Faisal's situation as well, that we don't necessarily want to give patients the whole gamut of things because we don't know what's going to be relevant to them, but we want them to know that we think it's legitimate and that there's help available.
And that's really the Pleased model, that you give the permission to talk about it. And it was so wonderful to see there was actually a study on women, pregnant women, using the Pleased model to approach them. So I think I have a question for both of you that addresses the partner. And the first one is actually from Daniela to Faisal, so it's not something we planned, but it says that, Dr. Faisal, how do you address the issue of men feeling excluded or losing primacy when they experience a woman turning towards the nurturing of a new baby and having emotional and sexual energy very little from the husband? So how do you address that with women? And what, I mean, some do say this is normal, or how do you address it? This is abnormal. How do you address it?
Well, it's very interesting that in one of the papers, Dr. Daniela, one of the papers, the male sexual desire was one of the determinant factor of the postpartum sexual dysfunction. I think there is a lot of psychological counseling that some of us give to the male partner in this case, because as Professor Girardi said, there is a feeling of marginalization, there is a feeling of neglect, there is some kind of support they are expected to give, but they're not giving or giving partially, and that really affect the intimacy part that really impact the sexual relation. In fact, one of the interesting papers I have read, it's about the neuroplasticity that happens to fathers. There is some kind of neuroplasticity that drops testosterone level because it needs, apparently this transition to fatherhood needs to go into a lower kind of ego and lower kind of libido that drops testosterone, which I find fascinating because the same thing happens to the mothers. I don't know how much is that really, but it's a decent paper with a decent, but I think we should, as you said, consider very much counseling the male, the expectations, the return, the non-coital activities, other forms of intimacies. That's really important because many times the return of the sexual function on the female side is very much a function of the understanding, of the intimacy, of the support of the male partners.
Oh.
Yeah.
So then we have another question also about the partner that comes from Dr. Janaten in the Netherlands. And I think this is to you, Daniela. I'm going to address it to you.
Okay.
And he asked, shouldn't we pay more attention to the sexuality of the male partners? And you just did, Faisal, when we looked at pregnant women. When the woman has cancer, goes through the first childbirth, men are confused, if not very confused. And for a good amount of men, sexuality is maybe the most effective way to reduce their confusion and stress. So when we help them through the complex period after, in this example, cancer of their wives, we maybe could prevent long-standing sexual problems and even separation. So do you have any comments to that?
That's a great question, actually. You know, so I think it's very important to help the men understand what happens to the woman's body, both, you know, after pregnancy and delivery and after cancer treatment, because men don't, or partners generally don't always understand all the different physical changes that happen to the body and how that affects the function and also the kind of distress that the patient lives with that may diminish the patient's desire. I'm a big advocate also to counsel the patient about the needs of the healthy partner, to destigmatize the needs that the partner might have. You know, they go on regardless of the patient's cancer experience and the guilt that the man, in this case, might feel about his own sexual needs. It's important for, you know, sex is always best if it's mutual, right? And so for the sake of mutuality, I think both members of the couple really need to understand each other's position. And, you know, I had an experience, just a brief case vignette of a man who was receiving testosterone treatment for another reason, not cancer related. And at 72, suddenly he just blossomed and his sexual desire went up and he just felt like, you know, life was starting over. And he began to chase his wife around the bedroom and she was terrified and panicked. And as it turned out, she was a cancer survivor. And so her sexual interest was nowhere. And really, they had to be counseled about the differences in their bodies, how they reacted to them, and find a solution that would work for both of them. And so, you know, it's a long-winded answer to your question, but I think the partner's sexual desire, it's very important not to be stigmatized, but he does have to be educated about what the patient is going through. And then the patient has to accept that the partner has legitimate needs.
Yeah, a very important thing and point, and I think that goes for the partner to pregnant and women having given birth. Faisal, it's the same that, I mean, both partners in the couple have their needs and they need not to be stigmatized. There's a question about the screener you mentioned, Daniela. Is something that can be shared, I think.
Yeah.
But the webinar will also be available at the ISSM website, so everyone can go there and see the reference. There was a reference to Dr. Bober, so you can find it. But Daniela is also happy to share it. There is another question for you, Dr. Wittmann. Could you speak more on the progress and promise/potential of the nerve-sparing surgical approaches? How big is that field of the study beyond the one study you mentioned? Is something we know a lot about, or is it just a pilot study, or where are we with the progress of these nerve-sparing?
So I was not really presenting so much a study. This was really just an article about sexual recovery after bladder cancer. This is something that in the United States already exists in practice, that surgeons are really trying to see where they can do some organ and nerve sparing. This is already a traditional approach for men in prostate cancer, nerve sparing. And they're also trying now to see whether they can spare the prostate in bladder cancer. So this is something that if looked up in PubMed or in some kind of a medical database, I think there would be articles that would speak to it, more expertly than I can. So it's in practice already.
Yeah, okay, great. This is a question for you, Faisal. Has there been studies looking at the relationship in lesbian relationship after birth of one of the partners? This is something we very often forget, that we don't have a lot of evidence on non-heterosexual couples, but do you know of any studies or any clinical experience?
Clinically, myself, yes, but I did not find really something serious, something genuine in the literature. But if we have to extrapolate, I would imagine it would be less of an issue in relation to intimacy, because of the ability of a lesbian couple to really develop ways of enjoying and expressing intimacy through non-coital and through other kind of non-sensate focus communication. It will be much less acute, if you want, and much less of a problem among lesbians as compared to heterosexual couples.
Do we know anything about non-heterosexual people with women with cancer, Daniela?
Well, I think that non-heterosexual women with cancer, a couple of different things. There's perhaps an ability, as it is always in same-sex couples, an ability to empathize with the physical changes, which is a little bit harder across the different sexes. That's number one. The other thing that's really important is that these are maybe not so much today in certain countries, but these are often couples who do not have as much family support as heterosexual couples, just simply because sometimes they've been rejected by family. They have non-traditional support. So to do well and to thrive, they really rely on other resources, and other communities and clinicians really need to think about that. And I have learned that people who are from different ethnicities and who may be gay or lesbian prefer to have support groups that have members that reflect them. They don't like to be referred to groups, support groups that are heterosexual or, other groups. So in thinking about supporting these women's sexual experience, it's helpful to connect them with other couples that are going through it.
Oh, very interesting. That's a question, and I think it can actually go to both of you. It says, thank you for such an interesting webinar. Thank you for that. Can you express your opinion or experiences or known evidence on the role of personal technologies like wearables, mobile apps in self-management of the sexual functioning? So I think maybe you don't know if there's any, what do we know about it related to pregnancy and childbirth and cancer, or if you have any comments on that.
And you mean in reference to self-care?
Yeah, I think that is like there are many new technologies like wearables, mobile apps that you can use. Is there something that is helpful, that can help in maybe teaching or promoting better sexual life?
What we know is there are the self-care projects conducted by the WHO that tackles on certain aspects like STIs, like menstrual hygiene and stuff, not directly with what we know about like the female sexual dysfunction, not in that regard. It's left to the international organizations through their social platforms that try to raise awareness and build knowledge for people around that. But a specific application that helps women, pregnant women, around their sexual function, I'm not aware of this. I don't think we have something like this apart from the raising awareness and knowledge thing.
Daniela, do you have any?
Yeah, so I'm only aware of one website. It's not an app. It's not a wearable. It's a website that was organized by Dr. Shover, who was sort of a pioneer in sexual health research. It's called Will to Love, WILL 2 Love. And it has a lot of information about sexual recovery after cancer. It has videos with survivors. It has tips and so on and so forth. So there is a robust amount of information.
Do you think people will find it if they Google Dr. Bober, B-O-B-E-R?
Shover. Well, let me just go on.
Oh, Shover, sorry.
Yeah.
Yeah.
Let me just. Oh, you know what? I can just also put into chat.
Yeah, can you put it in the chat?
Yeah,
Oh.
I can put into chat will to love. Hang on.
Great. So
And-
while you do that, I'm going to say that I can see that Dr. Heyman from Copenhagen is on this webinar. I know they developed for women with breast cancer an app with like a program that you follow that deals not only with sexual health, that a minor thing in it, but also with psychological health. How's your relationship? What happens during all the stress that you have with your relationship? How do you nourish your relationship? So I think it's something we're going to see in the future, that we are going to add new methods to help people also to do it in the pace they want to do it, because sometimes it might be difficult to go to a group therapy in a clinic, but you might like to do something at home or do it when you have time and do not feel too tired. There's a question, or more a comment, that a lot of oncology providers still see sexual health as insignificant and not worthy discussing at the onset of treatment. And I think, as I said in the beginning, we really always conclude this, and I guess it's the same with gynecologists that take care of pregnant women and postpartum. So how do we go from there? Is it because it's so difficult, and we also always need to think the biopsychosocial model, or how do we do it better, both for pregnant women, postpartum, and for cancer patients?
I think you have to make it important. You have to. It's like the early days of bringing sexual health to the clinic in the first place. So this is just saying, like, women are demanding this. There is really total neglect, or almost total neglect, of sexual health in cancer survivors and in the pregnancy and the postpartum. And this is part of the integrated complete care. You cannot do a care for a cancer survivor or for a pregnant postpartum if you don't address sexual health, which is bothering, which is affecting, which is serious enough for their life and for their well-being. And we have to address this. It has to go through a project that will go through the curriculum and the training, and they really create a lot of noise and demand around this. I mean, it's important. And also starting highlighting this in our meetings, in all the international regional sexual medicine. And that's what I'm writing an email right now for you in a minute.
Oh, that's great.
Highlighting this, because when you position this, it means ISSM is giving this an importance. When WAS is doing this, it's giving this an importance. So people start realizing this. And then you go through your social platform addressing the public and women that this is important, you have to demand this. Of course, with the implicit, with the giving permission in the background, that they can talk about this, and the provider is ready to do this. You have 100 people now participating, thanks to all, which means they are very much interested in learning on how to address sexual health issues in cancer survivors and in pregnant women. So I'm sure you have several hundreds out there who are willing to attend, but they cannot attend for different time zone problems, commitments, whatever. We have to make it happen. We have to make it important.
I agree with that completely. And I totally support exactly what you said. I also think that we have to go beyond sexual medicine societies. We have to present our research in oncology or gynecological scientific meetings to alert people who generally wouldn't have any access to that information, to this kind of information, because it really needs to go into clinicians' training, as you said, and it won't go there unless the senior people start seeing that the research shows that patients are really suffering and that they are neglecting an important part of their lives.
There's so many great questions. We have about 4 minutes left. We will stop in about, but I have to mention two things, because there's a I was put my attention to that the ISSM actually just published a book that is available as an open access book, that is about midwifery and sexuality. So I think everyone who's interested, go to the ISSM, not the ISSM, but the European Society for Sexual Medicine. They have these open access. And then there's also a comment from Isabel White saying that there's a UK charity for LGBTQI plus people affected by cancer called Live Through This. And this is where they would refer non-heterosexual people to, and maybe other people know of other projects and other possibilities in other countries. So I think, can we have one more short question, Omar? Is that okay? Because I think this is really interesting too. It's for you, Dr. Faisal. Does being a birthing partner during delivery have an effect on male sexual function postpartum? Because I think this is something that might be discussed. Is it positive or is it negative that the
very good question. Engaging males early on, or the partner, but I'm referring in this case to the male partner early on, definitely affected very much the expectations in a positive way, reflected positively on the intimacy, and reflected positively on the smooth return of sexual function in the broader sense. It's a very good question. Definitely, it was a positive thing.
Yeah, thank you. And I think maybe it's the same with cancer patients, that if you bring the partner actually to the clinic, they will also, it will be better for their sexual life and communication. So by this, I want to thank you, the audience, for all the great questions, for being here. And I want to thank you, Faisal and Daniela, for excellent talks and discussion. It's always a pleasure to listen to you, and we could use many more hours, but I'll give it back to you, Omar, to close the session. Thank you so much.
Thank you.
Thank you, Dr. Gerald. This is wonderful, webinar, and really excited and phenomenal discussion, really. And I do have, actually, if I have time, a question and a comment. The question is really about the pelvic trauma, females going through, for example, car crashes or road traffic accidents, gunshots. Unfortunately, we see that here in the United States. Younger women actually go through this. Any comments from the esteemed faculty on this area? I know we covered birth issues as well as cancer-related issues, but any trauma-related rehabilitation kind of program that you're aware of?
I just reviewed, Omar, in the last slide of my talk. It was a comprehensive lit review on this. And definitely there is sexual dysfunction across all the domains, unfortunately, in this case. But we don't have any standardized algorithms on like the burden of this problem. Who are they? But they specify it's mainly young people, underscored, underseen. And there is no standardized way of dealing with this, like the approach, whether you have starting physiotherapy along with pharma therapy, you start pharma and then this and then that. We don't have any agreed upon algorithm or armamentarium to go around this. And probably I think this is another area that we should be also focusing, handling, dealing with. Definitely, yeah. But there's nothing. And this paper is published, I think, in the Sexual Medicine in 2023 or something. Very fresh paper, very depressing. There is nothing serious. There is nothing relieving from the review.
I totally agree, actually, and there's maybe also like a negative impact on like mental health as well as reproductive health. I mean, the trauma they have to go through, recovering from the incident and affecting their lives afterwards is a real problem.
I think the urologists are taking all the action.
So can I just give you a quick clinical vignette?
Yes,
of course.
I once had a very interesting conversation with one of my urology colleagues who used to work in an area where there are mines, and when the mine workers would have terrible accidents and come to the surgery after the accident, and their pelvis would be a big problem. He used to find the pudendal nerve and try to put it under the skin somewhere where the man could reach it so that he could stimulate it to orgasm after he recovered. I've asked my other urology colleagues whether they ever thought about something like that, especially for penile cancer or whatever. Nobody ever thinks about it. So this is an awareness that should be, we should be probably promoting. Thinking about accident survivors' sexual health.
Yeah, absolutely. This is really good points. And really, my other comments about the partner satisfaction in the non-heterosexual population. And we recently published a paper in Current Urology Reports on this area. And actually, I was inspired by Dr. Whitman giving a talk on this at the ISSM, and Dr. Giraldi as well at the last Miami meeting in ISSM. And there was like a paucity and lacking of really data in this partner satisfaction for couples who are non-heterosexual. So I would obviously encourage more research in this area, as you advocated in your talks. And I mean, there's only like a handful of papers discussing partners satisfaction. This is an area of interest of mine as well here. But with that, I'd like to kind of close the session, and I thank everybody for great participation from the faculty, moderator, Dr. Giraldi, and also our audience. And really would like to also announce the upcoming webinar we have scheduled for May 25 at 11 a.m. UTC. This will be on very exciting topic, sex toys, wearable devices, and appliances for sexual pleasure. From a global perspective, we want to be a U.S. and non-U.S. kind of European, Asian kind of discussion on the widespread use of sex toys in our field. And with that, I'd like to thank all the ISSM team who helped us making this a successful webinar. And this webinar is going to be also available online on demand for you review in the future. Thank you again, and have a wonderful day.
Thank you very much.
Thank you and goodbye.
Thank you.